want to do something a little bit different, almost like a quick fire
Let's
round.
go.
How did it all start for you in terms of dentistry as an option? Was that just something within the family, or were you an outlier?
Uh, how much time do we have? No, because who decides when the treatment is finished? It's the patient.
That's a good question. That's
It's the patient. It's the patient.
Thank you guys for being with us today. We've got a very special guest. I'll give a little bit of an intro and then he'll give us a little more information that we may not have readily available. So I've got Dr. Stephane Reinhardt, who graduated from the University of Montreal in 1992. I was born in 91, so he's been doing this for a long, long time.
Don't say things
Excited.
like that.
I'm excited to learn from you today. You've been using aligners from 2004, over 1,500 cases. I'm sure that's probably growing from when this was put out. And he teaches on aligners for the Clear Institute. He puts out so much information on aligners that, if you're a beginner, you could get pretty confident from just the free stuff that he shares online. And even me, having been in this a few years, I'm still learning quite a lot from the content that Dr. Reinhardt puts out there. I only wish he was in the UK so that we'd have more access to him. But no, thank you, Dr. Reinhardt, for being with us today.
Well, thanks to you, Dr. Arnold. It's a pleasure. It's always a privilege to be able to again share my passion, my knowledge and experience of clear aligners, what it did for me in my practice, and my patients, my team, with colleagues all around the world. I mean, I'm very fortunate to have the chance to do it, and I've been in UK a couple of times. Last time was I was in Wales, but never in your area.
Yeah.
Preston, Lancashire. Wasn't there, so I have to go, and it's always a pleasure when I can be there. We always have fun. We share. I come from the province of Quebec in Canada, and we really share the same type of humor. We're all big fans of the British humor. British music was always a big thing in that part of Canada. So yeah, always a pleasure. And looking forward. I'm actually in Germany, so not that far
Yes.
from where you are.
So how did it all start for you in terms of dentistry as an option? Was that just something within the family, or were you an outlier?
How, how much time do we have? No. You know what? I decided there was nobody in my family in in dentistry or medical field or whatever. At the age of 10, I decided I wanted to be a dentist, and the reason is pretty simple. I had so much fun going to my dentist.
Okay.
The dentist I had was, you were going there, everybody was having fun, everybody had a smile, and for me this environment was appealing, and I just wanted to be that guy. And the funny thing is, he had a son of my age, and I was like, oh my god, I would like to be him. And it I don't know why, it's just the environment. The funny thing is that I started learning about orthodontics because of that dentist.
Mm.
And I was able to tell him, when I became a dentist, that big reason, big part was because of him, that he gave me this. I just wanted to be a dentist because of him. And I
That's
never regretted it.
so sincere because one of the things that comes across through video, surprisingly, is that you seem to have a lot of energy, and you don't seem to be the typical stereotypical dentist. Low energy, very scary, uninviting. Was that something that's just you in your character and your nature? Yeah.
I Yes, I think this is how I am, and for me, I always need to have fun. If I don't have fun doing something, I'm gonna stop doing it. I've always been like that. I was like that when I was younger. and I'm still like that. So you were talking about the videos, education. I have so much fun doing that. I have so much fun even doing the editing. I do my own
Wow.
editing on the videos because I like it. Because I always, okay, let's put this and let's put this and then I mean, this is one of the things I learned during COVID. It was one of the positive thing for me during COVID because I learned all this and I have so much fun doing it. So when I have fun doing something, it just pushes me to continue. And one of the thing we had at the clinic was always I was saying to my team, when we're in the clinic with patients, it's showtime. I mean, we all have problems. We all have things that can happen in our life, and we need to do it. We need to know it. I mean, if one of the team member has a problem, we need to know it because we have to support them. But in front of the patient, should never show because it's not fun going to the dentist. Let's face it, it's not a fun place. And they take the appointment, they come to the dentist, they take the phone, they take the appointment, they pay for it.
Mm.
So, can we at least have fun, have a smile, and make this experience as positive as possible for them?
Yeah, 100% agree. And I hope that my patients also see that I'm trying to make it as, pleasant and an excellent patient journey for them. I just want to take it to you graduating and then you starting with the liners. What was life as a dentist like for you then? And then what made you then change into becoming a provider for aligners?
Okay, so I graduated in 1992 and I opened my practice in 1993. So a year
Oh, wow.
after it took a year, yeah, to build the things, and you know how it is. We were two partners and we started from scratch. So we didn't buy an office with patients. And we just thought at the time, no, we're going to open the office and there's going to be a line of patients waiting outside. And it's going to be, and it wasn't like that at all. It was difficult. We had to work in three different clinics to just be able to pay the rent and everything at the end of the month.
Wow.
So it was not easy, but we just continued and continued. And what happened with orthodontics is I don't know how it is in the UK, but from what I hear about everywhere in the world, it's the same thing. We finish university, we know a little bit about everything, but we know about almost nothing about orthodontics. It's like something we cannot touch, something we cannot understand as general dentists. Just don't touch this, don't do this,
Yeah.
touch it. No, 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 this is not for you. You need special skills for orthodontics. And I mean, we could talk and we could do a whole podcast on why it is like that, but for me just made no sense and I wanted to learn more, and the reason is because I wanted to treat my son at the time was that was 1998. um, he was biting like this. He was a class 3 with only 4 incisors already. And the mother was a class 3. She had orthodontic surgery. So I wanted to treat him. I had no idea what to do. And at the age of 3, I said, I have to do something. So I went to my dentist. I told you about my dentist. He was giving courses. He was interested in orthodontics. He went to a United States, get some private courses, and he was giving some education to dentists in Quebec, in the province of Quebec. So I went there. It was a 3-year program, and I did this. And this is how I started integrating orthodontics in my practice. That was 1999. I treated my
Was that
son.
fixed orthodontics?
This is ortho because I'm a general dentist, but that was regular orthodontics with appliance, braces, and all these things. So
Yeah.
99, this is when Invisalign just became a company. I think in 97 and 99 is they started talking about the product to orthodontists only. General dentists were not even able to use the product
Mm.
until 2001. And so we start, and in Canada, we're always a little bit after what happens in the States. So we started hearing about it maybe in 2002, something like that. And one of my friend once phoned me and said, I just saw this thing. I just received at the time he was receiving something called a profitable dentist, and they were talking about new trends in dentistry and everything. And this was on the future of dentistry, and
Mm.
they were talking about Invisalign showing a clean check, and he said, you have to see this. You're going to go crazy, because I was interested in technology at the time. But digital, I mean, there was no digital technology at the time. It's just when those iPhone, all these things didn't exist. So when I saw this clean check on the screen for the first time, for me, that was the future of orthodontics for sure, but that was the future of dentistry. And
Yeah.
since my friend was the same thing, we did our orthodontic courses together. Since we already had the knowledge, we decided, so let's try these things. And the thing is, Dr. Arnold, we were saying to our patients in the informed consent, in every case, we're going to start with clear aligners, but we probably will have to finish with brackets and wires. So we do as much as possible with clear aligners, and we will see. But
Yes.
finding what happened is that we were able to finish our cases with clear aligners. Of course, we were not doing the same type of cases we're doing today. We were, able to select our cases, predictable cases at the time. But these, I mean, we just saw that these things
Yeah.
were working. I mean, and I heard everything at the time. You're doing compromised orthodontics, you're doing compromised dentistry. How can you
Yeah.
move teeth with plastic? It's only for small cases, relapse, name it. I heard it all. Even still today, and I'm sure you can hear it too, dentists saying, or orthodontists, you cannot move roots.
Yeah.
You cannot move roots with clear aligners. I mean, we're not bending teeth, we're just we can
Two,
move
two,
roots.
two
We can do whatever we want.
two
So
things
this
I
is
want to
how it
ask
started.
from there is number one, just give us a flavor of what that interface was like between you and the clean check compared to now. Some of us will never know what that was like, and it was like maybe two weekly changes at that time, maybe. And then the other question is, I guess from yourself, your journey, you had that prior orthodontic knowledge with fixed, learning about fixed. Whereas I find some people might not have that and struggle to even start their first case, let alone their first, let's say, 10 cases. So, yeah, give us a flavor of how it was in terms of the clean check when you did it. And then, what advice would you give to people that want to get started with the liners, but they don't have that prior orthodontic knowledge?
Very good question. First one is funny because, yeah, I remember again, like I told you, it was new. So the clean check at the time, we were just, my God, that was again the future. If I would see now the clean check that we had at the time, would say, this is really past. One thing is we were not able to do any changes ourselves on the clean check. There was no clean check pro where you could yourself move the teeth, add the attachments and everything. So everything had to be written to the technicians. We were limited on the types of attachments that we had. And again, we were selecting our cases because we didn't think it. I mean, there was no studies at the time. There was nothing on clear aligners saying that you really had to believe it to
Mm.
and to make it work. We had to figure out a lot of things. So we were learning as the product was evolving. We were changing every other weeks. Yes, patients were wearing the aligners 2 weeks, and the material was not the same. It was
Mm.
really stiffer. It was another type of material. And we might ask ourselves where did this 2 weeks thing came from? I mean, who decided, okay, it's going to be 2 weeks? And it's just that they were looking at the parameters of movement of every aligners
Yeah.
and compared this to brackets and wires, fixed orthodontics. And they just told themselves, well, let's be safe. Let's, put a little bit less. So 2 weeks seems like it's a safe zone where we shouldn't do any damage to the teeth or the roots, whatever. And this is how it really started. And again, we learn as we were using the product. And one of the thing I like, I mean, I've been using Invisalign for 20 years, almost 20 years now. And I'm not, with the Clear Institute, we're completely independent. I'm not a speaker for Align. I'm not a, yeah, I speak sometimes to their meeting because they ask me to do it because they see that the dentists who would, like you said, do the courses with the Clear, they do more cases because they understand better. But I have no strings attached to any dental company. I wanted to be independent because then I can say whatever I want. But the thing is, Align over the years, I mean, they do two things. They do aligners and they do scanners. So all the money they put in research and development goes in improving the product. And this is one of the things I like about Invisalign is how it just got better and better and better and better with time. And the ease, how the software is easy to use as well. The ClinCheck software, the possibilities that we have with the software are just incredible. And now you can see that they're targeting
Yeah.
general dentists more and more. Look at the new thing. I mean, the Smile Architect. Smile Architect is where you can build your restoration inside the ClinCheck, and you can plan the movement of the teeth. So this, I mean, this is for general dentists. And this is why, and it brings me to your second question. This is why, for me, general dentists have to integrate clear aligners in their practice.
Yeah.
Um, it's, I mean, not tomorrow, not in 1 week, not in 1 month. Now they have to do it now. And yes, the problem is a lot of general dentists have barriers, and one of the first barriers is probably ethics. It's orthodontics. I mean, can I do it? Can I touch this? Can I really move teeth? I'm just a general dentist, and this is something I hate so much. I hate the term general dentist. For me, general dentists are now ortho restorative dentists.
Mhm.
We're not general dentists anymore. I mean, we have to incorporate tooth movement in our everyday dentistry. It
Yeah.
should be part of our treatment planning. We should be as comfortable talking about using clear aligners to our patient as we are talking about any restoration. But it's not something you learn in a half-day course. It's
Mhm.
not something you learn like just by doing, a webinar or this is not how it works. I mean, if you, I never placed an implant in my life. I never did. I never did any surgery because I had partners. When I decided to do the orthodontics in the practice, my partner decided to do the surgery, implants, and everything. So we completed each other. But
Yeah.
if tomorrow I decide I want to do implants, I'm going to do a whole curriculum. I'm going to do a lot of training. And it's the
Mhm.
same thing with clear aligners. You have to take the time to learn. There is a learning curve because the patients, and you do it. I mean, patients we treat with these are not Invisalign patients, they're orthodontic patients. We're moving teeth. This the tool that we're using to do it. But
Yes.
plastic doesn't move teeth. What moves teeth is force. So we have to understand the principles, we have to understand the mechanics, and we just have to take the time to do it. Now, doing theory is something, but you may do like 30 hours of theory. If you never put your hands in saliva and you never start cases, you will never learn. It's like somebody who's deciding to learn how to play piano and
Yeah.
only does theory and never practices. They
Yeah.
will never be able to play piano. So it's the same thing, but we have to change our mindset. We have to change how we see ourselves and
Yeah.
stop separating orthodontics and the rest of what we're doing. Those two things have to be incorporated together. And now I think we have the possibilities to learn. I mean, yes, you talk. I mean, I have the Clear Institute. You have in the UK, you have Aligner Consulting. There's a lot of possibilities out there for general dentists who want to take this seriously and
Yeah.
learn how to use clear aligners.
Yeah.
And
Do you
the
feel
thing
like
is,
you've been saying similar things from when you started training? Well, when you started as an aligner provider, in terms of the same objections are coming up year after year, because you know, I feel like it's like you've answered so well. You know, dentists are doing ortho restorative, you know, for the benefit of their patients. Um, do you feel like things are changing and that the dental community is coming round to this?
I from what I see from young dentists, I see it's changing. The thing that sometimes the problem is, like you said, is that they're not interested in learning brackets and wires.
Mm,
They don't want to know. And a lot of times in some of the courses, you have to go through, learning the basic of brackets and wires to get to the clear aligners. And some of them are just integrating clear aligners because they have to. But I was lecturing a couple of weeks ago in the States to a group, and they're almost all doing brackets and wires. And I was talking about clear aligners and just telling, guys, you have to open your eyes. This is where it's going now. This is where we are. It's just taking the market. So, and the idea, I think, of all these the courses now is to learn orthodontics, but apply it with clear aligners. And this is what's appealing to young dentists. But I think, from what I'm seeing, young dentists are more open to than maybe older guys like me, who are sometimes old school and thinking again these things don't work. And so I see a change. The change I would like to see is between the relation of general dentists and orthodontists. This is the change I would like to see, where we would work together. And I really think that orthodontists would just do more cases if they would teach general dentists. Because I decided at one point to limit my practice to orthodontics and now clear aligners. But most general dentists don't want to do that. They want to do some cases, predictable cases, again, integrate tooth movement maybe to take, let's say you have a restorative case that would be a complicated restorative case, but because you integrate some tooth movement, you're going to make it a more predictable restorative case. This is something for general dentists, but a lot of them don't want to treat growing children. They don't want to treat complicated cases.
yeah,
And sometimes they're not able to see the problem. But if they would be educated by orthodontists, they would be able to diagnose better, and they would refer more to orthodontists. And this is, I think, my wish for the future is that we can end this kind of, I don't know where it comes from, this, that you're a general dentist, you're an orthodontist, and just work together and join our forces, and being able to have some help from orthodontics when we need it. And again, education. Everybody would gain from that.
yeah, 100%. And I've found that I refer to a local orthodontist as well, and I'm able to ask him for advice on cases, and case I think this is way beyond me. I easily refer to him, and even when I put out posts on social media, he'll say to me, "Did you think about this in your planning?" And it's all helping me to improve and develop as a practitioner as well. One thing I wanted to ask you is, I would love to get to a similar stage where I restrict my practice to clear aligners, and I want to ask you what what would be a great pathway for a general dentist who wants to get to that point of exclusively providing aligners for their practice. I'm asking this a little bit selfishly. How does that look to you? What was your progress to getting to where you are now, and what do you think that can look like for someone starting from fresh?
For me, what happened again is that in the practice we started two partners, and when I did that decision of integrating orthodontics, my partner decided, okay, I'm going to go into surgery, implants, and everything. Then we added a third partner who
Mm,
wasn't doing orthodontics, so I was just doing more and more and more cases. And it to a certain point where I say, I'm gonna dedicate my practice to orthodontics because I was having fun doing it. I mean,
yeah,
for me, what I like about it is the relation you build with your patients. Because and at the time with fixed orthodontics, I was seeing them every 6, every 8 weeks. And So you kind of build a different um, I don't know. It was not the same. You know them better. They know you. It's like a stressless. A lot of patients, they come to the dentist and they don't like the dentist, and sometimes
Mm,
it's the first time, it's the first thing they say. I don't like the dentist. I don't like. How many times have we heard that?
yeah.
And but with orthodontics, there will not be any injection. There will not be there's not that stress is not there. And
Mm,
like I told you, I like things when they're fun. And for me, it was easy to have fun. I was treating a lot of kids, teenagers, and I'm having fun with kids and teens. Sometimes I feel like I'm still a kid in there. So I'm having fun with them. And it just, it wasn't something from the start saying I'm gonna dedicate myself to orthodontic. It came with time as I was doing more and more cases. And now, as an old dentist, I see it as something that I can do for a long
mm,
time, especially with clear aligners, because let's face it, what are you really doing at the chair? A lot of the work is done spending time on the ClinCheck, on the computer, treatment planning, thinking. We are there most. When things are going well and following like they're supposed to. You just go see your patient, say, just continue the good work. And what can you do? The thing is, we have to be there when things are not following, when there's some trouble. And this is where we have to figure out what's the problem, and what's find a solution.
yeah.
And sometimes I'm with my assistant, my hygienist, they're like, and I'm sitting at the chair and just looking at the patient,
Yeah.
and they think I have a seizure. They think I have something. You're just trying to figure out what just happened there, and that's
Yeah.
the fun of it. For me, it's like being a detective, trying to
Yeah.
figure out. Okay, and it's the same thing when you see the patient in consultation. Why is
Yeah.
it like that? What happened? Why do we have an open bite? Why did the teeth shifted on one side? And
Mm,
it just for me got more and more interesting. And I have young dentists. I have two dentists at the clinic now, two associate dentists. They finished university 2 years ago,
yeah.
and they did the whole program with the Clear Institute, and to start again with clear aligners. And I saw that, okay, gave them the confidence, but because it's all about confidence, you need to get that confidence that you can start cases,
Yes.
and they are doing it. But I see that they get more and more comfortable with it. They do more and more cases. And I think that some dentists, maybe the majority of dentists, will decide to keep it like that, because I like to do a little bit of everything. And maybe
Yeah.
some other dentists like you, from what I understand, is that you would like, to dedicate your practice to this.
Yeah.
So if you want to do it, my advice is, well, is it possible to do? What kind of practice you have? You have a solo practice, or do you have a lot of other, associates, partner? Or if not, develop a system of reference in your area where
Mm,
other dentists would refer you some patients. And you know how it is right now. Social media, webinars,
yeah.
thing like that, for patients who would just find you and just you think you're interesting. And this is, we have Dr. Google now. We have,
Yeah.
yeah, that's it. So yeah, but I think it's a decision that somebody has to take. And once you take the decision, that okay, let's go. This is what, and then have a vision, have an objective. It's the same thing with cases. I coach some dentists and say, "What's your objective for next year?" I want to do more cases. For me, it doesn't mean anything. I want to do more cases. Okay, so if you do one more case than last year, you've done more cases. Did you reach your objective? What's your objective? You need a goal. You need somewhere you want to go,
Yeah.
and your team has to know about it.
Yes.
Because I say to all dentists, if you're trying to integrate these things in your practice by yourself, it
Yeah.
will not work. You need your team. They're the behind the scenes heroes. if I wouldn't be here if it wouldn't be for my team. They
Yeah.
just decided to, let's dive into this thing and to join my craziness of integrating clear aligners at the time. But and
That's
most
that's
of
that's
them,
really
I'm sure, are
useful,
still with me.
especially really useful because I'm at a point where I'm actually looking to start up my own practice early next year. So this is really helpful. I want to do something a little bit different, almost like a quick fire
Let's
round.
go.
Um, I was watching your shorts this morning. Um, okay, the first question is the clean check. Is it outcome simulation or something else?
Is it outcome simulation or something else? Uh,
Yes.
I will tell you what a clean check is. A clean check is a force system. The problem with the clean check is a lot of dentists think this is how the teeth will move, and it's not. It's the shape of the aligners, and it's how the force will be applied on your teeth.
Elastics, are they useful in aligners?
Yes, they are really useful, and we don't use them enough.
Yeah.
A lot of dentists
IPR,
are afraid of elastics. They don't know how to use them. This again can be learned, and they are really useful.
yeah. IPR, is it safe or dangerous?
It's safe. I'm not the one saying it. Scientific literature is saying it. Look at all the studies. It is safe. If you're not safe, if you don't feel safe doing it, don't do it. But you have to find another way to create some space. It's one of the options to create space. So, but if we're looking at scientific literature, we are backed up by science.
Um, Aligners don't give comprehensive results. You need fixed braces for that.
Mhm, mhm. Well, again, let's look at scientific literatures, and I just think of one article by Bushang, Peter Bushang, who is really not a clear aligner guy, and just showing that it's even faster. And look at everything. Look at the. I like to look at the angle orthodontists. Angle orthodontists, they're not attached to any company. Every orthodontist, I mean, the dream of being published in there. And there's a lot of articles now showing that we have predictability with clear aligners. The thing is, it depends on who is using them. So if you have experience, you have more predictability. The problem is when you think, again, that the clean check is supposed to show you what you're going to have at the end. This is where the problem is. But
Yeah.
yes, I've done both. And you know what? I'm going to, very quick thing. When I started, I told you when I started with this, I was telling my patients, we going to have start with clear aligners and probably finish with brackets.
Yeah.
Now I have patients that I started with brackets and I'm telling them we're going to finish with clear aligners.
um, in terms of, let's say, Invisalign, should I start with Invisalign Go, so only moving first premolar to first premolar, or should I start with Invisalign Comprehensive?
Mhm. Okay, that's the thing, there's a big difference. Like in America, Invisalign Go is not a big thing. And the thing is, when we get certified as general dentists, we can use comprehensive. This is, I think, a big difference with what we see in Europe, what we see in UK. I don't know how is it for you guys, but I think you have to use Go. Is that right?
You get
So,
to choose where
are
which
you-
one you start on. Yeah.
okay. As a general dentist, again, for me, it sometimes gets even more complicated if you do not move the premolars or the molars. I've seen sometimes terrible things where I've seen people doing expansion, but the molars are not moving. It's just, I mean, you can use comprehensive and decide not to move the molars and premolars. And for me, it's like I'm the dentist. I'm the professional. I am the one who should decide
Yeah.
what I move and what I don't move.
Yeah.
This is my
Class one molar relationships, canine relationships. Is that what we should be putting all patients to?
we should be putting our patients into a stable relationship. So for me, class one, class two, class three are classifications. It comes from angle, further modern orthodontics. but those are not lost. I have patients who are in class 2 and they're very stable. I have patients who are class 3, they're very stable. I have patients who are class 1 and they're very unstable. So I think our role is to explain to our patients what I tell them. If you want to be on the front page of the orthodontic book of Montreal University, this is what we need to do. But we could do this. There's not only one good way to do things. Otherwise, we would all do the same thing. But I have, for me, it's if I talk to you about a class 1 patient, class 2, you know what it means. But I have stability is something else. So we have to bring them to a stable position. And the other thing is the problem with dentists is we're all perfectionists. And sometimes, if you're like me, a little bit control freak, we want everything to be perfect. When you're doing orthodontics, especially with adults, it's not about perfection anymore because it's about improvement. And this doesn't come from me, it comes from Dr. Larry Gerald. He's an orthodontist, he's a lawyer, he writes the litigation a column in the American Journal of Orthodontics and Dentofacial Orthopedics.
Yeah,
Told me, Stefan, you cannot make it perfect. It
yeah,
has to be you're aiming for improvement all the time.
yeah. And that's a very real thing because with a lot of my patients, because I'm trying to be a perfectionist, I start to see a line of fatigue where their compliance is dwindling and dwindling, and now we're just stretching out treatment when they were happy 6 months ago.
Yeah. True, because we want to satisfy ourselves a lot of
Yeah,
times. It's hard because we see things and it's okay. I mean, sometimes we have to do it, but it's and some speakers, some you're going to go to lectures and going to tell you, I know they finish all their cases in 3 months, in 4 months, and every in one series of aligners. Well, I'm telling you, they're much better than me because I cannot do that. It's impossible. This is not how it works in my practice. And a
yeah.
lot of times, those speakers, I tell them, you should do more cases because if it works all the time, you don't do enough.
um, Treating children with aligners, is it easier or is it harder?
They are the best patient. I mean, they're the best patient. Mixed dentition is the teeth move like in butter, and we put attachments because we want to hold the aligners in because the clinical crown is so small. But they are excellent patients. They are compliant, and sometimes I treat the mother, I treat the kid at the same time, and the kid is watching the mother, saying, "My mother is not really wearing the aligners." But they are. So very good patients. So those of you who are interested in treating kids and teenagers, I recommend it. They're fun and they're good.
Yeah, I saw a child patient yesterday, and the way I'd set up the clean check was to have some overcorrection in certain aspects. And yesterday they were halfway to finishing their second round, their refinement stage. And I was looking at them and I was thinking, we don't actually need to carry on here because their teeth are tracked so beautifully that if I carried on, the overcorrection would actually express, so that was actually it surprised me, and I was just looking at her teeth for for a while, just thinking, what's actually happened here. So yeah, I'm starting to see that child patients can have really great compliance and things can move very well.
True. And you exactly did the right thing. And this is something that sometimes uh, dentists get caught in. They think they have to finish the set or the series of aligners. And like you said, it's perfect now. Why would we continue? Everything is good. Let's just stop there. And but it is effect. That's we something we see with children, and that usually you don't see with adults.
Temporary anchorage devices, TADs. Is there a real growing place for them within aligner therapy and orthodontics, or is it something that's always been around, but it's sort of making a comeback now? What are your thoughts?
I think it's making it's been around, was a big thing with brackets and wires, and then it kind of, went away a little bit, but now it's coming back, I think, because of clear aligners, and it gives us the opportunity to do even more. I think of, difficult movement, vertical movement, intrusion. So of course, it's an added anchorage, and it helps in some of the movements. Now, do you like to? I try to avoid them because it's and I try to find ways to go around them. But I know that sometimes if I would use them, I would just probably make things happen faster. But for sure, it's there, and we will see more and more of them.
Yeah. I've been seeing dentists that incorporate the CBCT scans into their ClinChecks to be able to visualize the roots as well and avoid collisions, that sort of thing. I think it's Dr. Michaela, a colleague of yours, or something that you know quite well. She was
Yeah,
talking in Manchester
yeah,
recently at an
yeah,
Invisalign. I think he actually made a video about it. Now that I think about it, about the drinks and the fridge.
yeah.
Um,
Exactly. Yes, I was at
well,
the
yeah,
summit. Yeah, yeah, that's it.
I think she uses that, integrates that. I'm on the verge of deciding, the benefit of using that. What are your thoughts on integrating CBCT with aligner therapy?
And I think in that lecture she showed a case where there was space where I mean, the idea was to close the space, and then you take the CBCT and you see there's no bone, there's nothing, something
Mhm,
that would we could not see on the panel.
mhm,
It's not something that I would recommend doing, all the time. But I think that for some cases like that, when you feel that impacted cuspids or things, it's there. And again, it brings us even more. I mean, you can see more things with it. Um, the problem I've seen, and this is something dentists have to understand, is that when you look at the CBCT on the ClinCheck, the
mhm,
bone doesn't change. So you move the teeth, but there's no bone remodeling on the ClinCheck. And a lot of them they get scared because all the roots come out of the bone, but it's always been like that. And the software cannot, I mean, pre, you know, try to guess how the bone will remodel. But
yeah,
there was a big at one point with fixed orthodontics, all orthodontists were taking CBCTs before and after, and they
mhm,
suddenly they stopped. Why? Because they didn't like what they were seeing at the end. A lot of dehiscences, fenestrations, things like that. But it's always been like that. It's just that we don't know about it. But definitely, this is again another added value of. But it's not something I do for all the cases, for sure.
mhm. Attachment selection. I find that I like using conventional attachments at the moment. That might change. There's optimized attachments. How do you approach attachments? And there's always new innovation to attachments.
Yeah. This is for me where we have to be careful because what's an attachment? An attachment is just changing the shape of the tooth. It's either there to make some get some resistance or anchorage, or it's there to help in a certain movement.
Yeah,
So we need surface. I mean, if we have a small attachment where there's almost no surface, it's going to be there for nothing. So for me, the biggest possible is better. I always put them as thick as possible. If I can put a 5 millimeter, I would put a 5 millimeter because I have more surface to apply the force. And a lot of times, this is the only place where the force will be applied. So when
yeah,
I see very small attachments for root movement, for distalization, for things like that, I mean, this is where we have um, to really think of what we're doing and where the force will be applied. And one of the trick I have is always imagine the teeth are in soft wax. If the teeth
okay,
are in soft wax, and I would ask you, say, Dr. Arnold, you can take your two thumbs, your fingers, to move the teeth. They're in soft wax. Where would you apply the force? And
yeah,
usually, this is where you put attachments. If I have a big rotation of a premolar, and I tell you can take your fingers to rotate the premolar, you would probably, you know, make some pressure on the buccal and the lingual and turn the tooth. So let's put an attachment on the buccal, one on the lingual, and one very easy trick is if you need a horizontal force, you go with vertical attachments. If you need a vertical force, you go with a horizontal attachment. So the attachment is perpendicular to the force you need.
Yeah. And I recommend people watch your short on the center of resistance. It
Yes.
explains that very, very well.
Yeah.
Um,
I mean, if you're interested about I'm a mechanics guy. This is what I like the most because for me, when you understand mechanics, you can understand everything. So if you yeah, if you're really interested, I mean, go to do some mechanics course because then you can really understand uh, and you can face any problem.
yeah, I like your saying. I actually had think like plastic. I'll actually ask you to expand on that in a moment because I had a case where I was planning, maybe even last week, class 2 diff 2 case, where the recommendation was to put bite ramps on the upper centrals, and this was just going to allow us to lose that surface area. Think like plastic came to mind. Can you just expand on that?
Yes. Um, we're using plastic to cover the teeth. So it's like, yeah, you're hugging the teeth. And this is how you will apply the force. Now, if you look at these appliances, um, they are stretchable. It's like a fancy elastic. They're stretchable, so they can be stretched. They are stiffer on the occlusal. The more you go to the occlusal or the incisal, they're more stiff. The more you go to the gingival, they're more flexible. Same thing if you have a patient with very long arches, they have like their wisdom teeth, and you would need a shovel to take an impression. It's a they're so the longer the aligner is, it's going to be more flexible in the back too. So we have to think about, because this is how we apply the pressure. So the example of the bite ramp is a good example, because if you have a class 2 div 2, the first thing you want to do, again, I would tell you, okay, take your thumb, and where would you push? What would you do? The first thing you would do is push on the lingual of the two incisors. This is the first thing you want to do. So it means this is where you need the force. Now, if you have a bite ramp there, what is a bite ramp? It's a void. It's a hole in the aligner. So
Mm,
I don't know if you try to I mean push and move teeth with air, but I'm not able to do it. I don't know how to do that. And this is why, because they put this there, it's better there, but we have to stop and think. Again, I'm pushing, I'm the plastic, I'm inside there. I need this pressure there. Maybe after the tooth is in position, maybe then you can put a bite ramp if you want to disocclude the posterior teeth, but and it's the same thing with power ridges. Power ridge, what is a power ridge? It's a little bump in the aligner. Now you're trying to procline. Okay, what is happening? I mean, you have a smooth surface, the enamel, you have saliva, and you have plastic. So when the teeth are moving inside, they're just sliding inside. So if nothing holds the tooth in the aligner with an attachment,
yeah,
it's going to slide. This is why, I don't know about your experience, but my experience with power ridges is most of the time when you're proclining, you're going to see a void in the where the incisal edge is,
yeah,
because the teeth are going up. So it really depends on where you want, what's the initial position and what's the final position.
yeah,
Where do you want your teeth to go? Because proclining a tooth like this is something, but I can procline like this.
yeah,
So if I want to keep my incisal edge at the same level, it's different than if I'm doing something like this. It's not the same mechanics at
yeah.
all. And this is again, so we will not use the same type of attachment, same type of mechanics. But this is what keeps everything interesting.
Yeah, no, I could do this all day in terms of asking you these questions, but what would you boil? Um, so for the beginner that wants to start to get to this type of level, what would you advise them to do where they're marrying the theory with the practical and not getting paralyzed to do cases?
Yeah. I think you need to first educate yourself. Go to a serious. Of course, the Clear Institute. Yes, I'm not here to do, like I told you, in the UK you have Aligner. It's not Aligner Consulting anymore. It's Aligner
Global
Academy.
Dental Academy
And yeah,
now, yeah.
global, yeah, yeah, that's it.
Yeah.
With Raman and Barry and all the speakers there. There's probably other places I don't know in the UK, and
Yeah.
I just don't think you're going to learn in a half day course. So do a complete. Like for us, somebody is starting. It's the Mocha 101 is 32 hours online, and we go. And the first thing is not sell aligners. No, the first thing is consultation, diagnostic. This is where it's still orthodontics. So you have to be able to select the cases and select the right cases. One of the biggest mistake I see with dentists who are starting, they don't know how to select their cases. They select cases that are too complicated. They use aligners and they don't have a satisfying result, and they just stop doing it. Or they, a lot of times what I hear, they are blaming the plastic. It doesn't work. It's because of the plastic. Funny thing is, when people are using brackets and wires and it's not working, it's never because of the metal. So when it's not working, it's not because of the plastic, it's because we don't understand how to use the plastic, and again, how to think like plastic. But these things can be learned. There's a learning curve, and I just start with predictable case. You have to learn and understand what a predictable case is. And I mean, really simple. I mean, the vertical movements are the most difficult movement to do with clear aligners. So if I have a class one case where the vertical is good and just a little bit of crowding, those are good cases to start with. But just go to, again, a good place where you can learn, where they are serious, where you have continuous. If you want, after that, continue and learn more, you can
Yes.
do it. People will support you. I think that's important. That's really important. But definitely you have to integrate clear aligners in your practice. And I'm not selling clear aligners. This is the easiest thing to sell to patient. It's very easy to start cases.
Yeah.
The difficult part is finishing cases.
Mm. How about for the experienced provider who wants to take things to another level? And let's talk about patient journey and experience. What do you see from your experience works well, in respect to the patient starting well, finishing well, from the point of them inquiring to them actually getting into retainers? What does a great experience for the patient look like in your view?
Um, the first thing, there's some studies on this that were out. What will make a patient compliant? What will make a patient wear the aligners? Because you need there's we need three things. We need three things to move teeth. We need force, we need time, we need space. The only place where we have control really is space. We can, decide how we can do some IPR, we can do some, but for force and time, this is going to be, connected to how the patient will wear the aligners. So if they don't wear the aligners, we don't have force, we don't have time. So
Yeah.
we need them on our side. It's a teamwork. And what will make patients wear aligners is if they like you. And this is again a lot of studies on that. If they will do it, and like with kids, with if they like you, if you have a good relation with the patient. I mean, for us, it's never about trying to, I don't know if you remember, maybe I don't know if you use them, but there's these compliance indicator for a
I've never
line
used
for
them.
a
Yeah,
team.
I've
Yeah,
seen them.
that's it. So that
Yeah.
was, it changes color. It's a blue dot on the aligner, and if you wear them well, it changes color and becomes white. And that came out with the Invisalign Teen at the time. So let's just check this, and you didn't wear your aligners. It's still blue, and this is not the type of relation I want with my patients. You
Mm.
just have. For me, it's about communication, about letting them understand why they need to wear the aligners. There's a reason why. It's not just because I decided you have to wear them 22 hours. It's just because the cells, the differentiation of the cells takes 4 to 8 hours. So if you keep your time removing the aligners all the time, you're just going back to the initial, we have to start again and start again. So They need to understand this. And the other thing is, as soon as we start with the treatment, then we become coaches for our patients. We are
Mm,
there to motivate them because you said it, after 6 months, they're not motivated as they were, and the teeth are, straight, but you're seeing things in the back. You don't like the occlusion. They don't really care about that. So we have to keep motivating them.
yeah.
We take pictures every follow-up appointments. We bring back the initial pictures to show them how it was, where we started. And people forget. They
Mm,
forget. They don't remember how it was. I had a patient who she was arguing with me that it was not her on the screen. Said, no, this is you. This is how we started. And that's it. But that's the reality. So we had the role of the team is to coach the patient, to make
mm,
sure that they will keep wearing the aligners, and to bring them to a certain point where, we all come to a point where I say to the patient, now we've reached a point where if you would have been like that, I would never propose you a treatment. But
mm.
since we are in treatment, there are still some things we can correct and blah, blah, blah.
Yeah.
Uh, just to avoid these patients who are saying, it's funny because it's everywhere the same. I'm just doing that, and you know what I'm going to say. That tooth here, and when I go with my tongue, it's not equal with the others, but it's everywhere in every country, everywhere around the world. So, you just tell them, I'm sorry, I thought you wanted me to align the front of your teeth, not the back. But that's it. So you come to a point where you say, if you would have been like that, you would never accepted to do a treatment, right? And
Yeah.
and you just nod, and you think you wait that they nod with you. But I see that, because we're in treatment, we can still do some little corrections. Are you interested in that? Because who decides when the treatment is finished? It's the patient.
That's a good question. That's
It's the patient. It's the patient. I mean, you cannot force anybody to be in treatment. If they decide it's going to be finished, it's going to be finished.
yeah.
So it's I'm not the one deciding. I'm the one to, I mean, I'm there to explain, I'm there to support, I'm there to give my opinion. But I mean, it's
Yeah.
like when a patient tells you, uh, 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 Dr. Arnold, can you tell me what should I do? What should I do? The
Yeah.
answer should be, I don't know what you should do. I have no idea. I can just do what I would do. That I
Yeah.
can tell you, but what you should do, I don't know.
Yeah. Uh, This is a different extreme, but I've become better at this now. There are certain patients where they would say, I think we could do a little bit more here and here, but they were very vague. So I did refinement aligners without fully understanding what it was. Um, and that didn't really make much difference to the whole process. We just wasted a few months. But now, I actually sit them down and say, okay, here's the scan. Help me understand where do you want to go now? And a lot of the times they're happy. They just want to know that they've exhausted the process and that they're getting their money's worth. So that's another extreme that I've seen where sometimes you have to be a bit assertive to say, okay, you feel like we could do more, but what exactly is that more?
It's very good. And it's again everywhere. It's the same thing with me, with my patient. I see it, and that's the best way to do it. Just show me, because for me, with my experience and everything, I see that everything seems fine. But I just want, just show me. And again, sometimes, like you said, they wanted to come from you. This is where, and I was talking about Larry Gerald earlier. Um, no, Larry Gerald told me something about informed consent,
Mm,
um, that it's a work in progress. And the informed consent we do at the beginning is very important. But what he said, and what nobody does, is we should do one at the end when we finish a treatment, saying, this is what we were aiming for, this is what we were able to correct, and this is what we were not able to do because of blah, 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 blah.
mm,
But the informed consent at the end, he said, is the most important thing and it's something nobody does.
Okay, that's the first I'm hearing about that one. Because normally at the end, I will do a retention consent form.
Yeah.
We'd have done it at the start, but we're now doing it again where they're going to look through it with me. They'll sign, and we know about the importance of retention. But this informed
Nobody
consent,
told me about retention. Nobody told me about retention.
one of the ones that I heard last year after I finished the case was my friends who had metal fixed braces. They never had to wear retainers. Is it because I've used the liners I've got to wear retainers?
That's it. Yeah, yeah, yeah. Yeah, the teeth. No, the teeth are selective. They know they use plastic, so we're gonna move back. I mean, you have the. I mean, in UK, you have the king of retention, Simon Littlewood. I
Yeah,
mean, I don't know if you know about him, but Simon, I mean, he's just, I think he spent this whole year studying and doing some research on retention. He's lecturing on retention. He's,
yeah,
by the way, one of the nicest guy I've met in my life. But and I had the chance to lecture uh, in Poland with him, and I asked him, am I doing the right thing with retention? And
yeah.
what he told me is that, you know what, we don't know what's the best retention. We
Mhm.
know we need retention. And for him, he said in his office, everywhere there was poster, no, all that smile, saying to patient when the treatment is finished, it's not finished. This is not where it ends. This is where it starts. This is
Mhm.
where I did my job, and now you start doing yours. Now
Yeah.
the how do you say in English? The ball is in your court,
Your
or
cock, your court.
and yeah,
Yeah,
that's it. So now, if it's you're responsible of retention,
yeah,
but and we have a consent also only for retention, because you know it is. You always responsible, and we're married with these patients. I think this is one of the difference between orthodontists and general dentists. We will keep seeing these patients in our offices. There will come back for their regular appointments, every 6 months, and we will see it. And if they see a difference, they will tell us. If they saw an orthodontist and there's a tooth that moved a little bit, maybe they will not take the phone to call the orthodontist. Or
yeah,
so that's one of it. We're married with these patients, that's for sure.
yeah. And choose who you marry wisely.
Oh, yes. This is one of the, I mean, if I can give another of my tricks, is when we do the consultation, this is where you decide if you're going to treat a patient or not. So we were talking about class 1, class 2, class 3 patient. I have class 4 patients. When I tell my assistants it's a class 4, it means we're not a good fit. In some cases, I think, what, your case is very complicated. We will need to refer you to a specialist.
Yeah.
Because it will not be good for you, will not be good for them. I mean, how many patient that you need in a day to just, completely scrap your day? It's just only one.
Yeah,
That's it. This is how it is. So no,
yeah.
no, there's no more time. I'm an old dentist now. No more time for cheap wine anymore.
I just want to pick up on that informed consent at the end, just so I've got it um, solidified in my mind. So you want to go through with them what you are able to achieve and what you were not able to achieve. Now, okay, when I first heard that, sometimes you don't want to tell the patient what you haven't been able to achieve. So
Yeah.
just tell us a little bit about how that conversation goes, and what are you trying to achieve with that informed consent at the end?
You know what? It's important because, and it's important that the patient remembers also. For example, you have, we were talking about, a class 2 patient, and you're treating an adult, and they would need a orthodontic surgery, but they have, the incisors are overlapping. They don't like it. They want to change the aesthetic 6. And you've explained everything, but you limit the treatment to that.
Hmm.
So at the end, the patient will still be in class 2. And I tell them, there's gonna be a day maybe where I will stop practicing, or you will move and go to another dentist. Now, I want you to remember that when you will see the other dentist, They would tell you, "Oh my God, you had orthodontic treatment, but you're still in class 2 and blah blah." And that's not the. I now I want you to remember this. I want you to stand up for me when you hear this, saying, "Yeah, Dr. Reinhardt told me. I knew about that." No, that's the kind of thing, because we are doing sometimes. I don't like to use the word compromise treatment, but alternative treatment. Like, again, no, not I don't know how it is, but I mean, for me, it's not everybody's. Yes, I want orthodontic surgery, and they don't. And even if you explained it, and this would be, again, if you want to be on the cover book of the cover page of the orthodontic book, you would need orthodontic surgery, blah blah blah. Now we don't have to do this. We can do something else if it's only the crowding that bothers you.
Yeah.
But they need to know at the end, again, this could not be treated, this could not be corrected because of blah blah blah. And sometimes it just, you have some ankylosed teeth, you have some reason, sometimes compliance. I mean, we were not able to achieve what we wanted because you were not wearing the aligners like you were supposed to, or your son was blah blah blah. And they know it, they know it. So it's just, the thing is to have it written in the file, because when it's not written, it's not true.
Yeah.
So
Do you get the patient to sign off maybe and then take a copy with them, or is it just more for your records as well?
it's more for my records. It's more for me, for my file, for my they could, I mean, they could have a copy, you could give them a copy, make them sign. But for, according to Larry Gerald, again, is if it's written in the file, then that's the important thing. Let's say in the case of litigation or something like that, if it's written in the file, that's good. He said, of course, the perfect thing is to have everything recorded,
Hmm.
but who does that? You know.
Yeah,
But
no,
yeah,
I have thoroughly enjoyed being with you, and I could go on for another 2, 3 hours. But if people want to find out more, get to learn more from you, what's the best thing for people to do?
I just go on the search, I mean, on Google, the Clear Institute, or go on the learn.theclearinstitute.com, and you will see, again, there's some free courses. Somebody who wants to start or not sure, we have an introduction to clear aligners course that is free, and it gives you a little bit an idea. And after that, I mean, we have online courses, live courses,
Mm,
again, big programs that were designed, like the MOCA 101, designed for those who want to start and have success integrating clear aligners. And then we have the 201 for those who are more advanced and confident providers and want to know more and understand even more things. And I mean, more courses are coming. I have a YouTube channel also. There's the interview with Larry Gerald is on our YouTube channel. Very interesting, 1 hour and a half on informed consent, on the ethics in orthodontics and everything. So
yes.
so you have, like you said, a lot of videos there that are interesting. You will give you an idea of how I like to do things.
Yes, fantastic. And guys, I would encourage you to check out the YouTube channel. I'm going to put all the links in the description as well. And guys, I will see you at the next episode. Thank you very much.
Thank you very much. Bye bye. It was a pleasure to be here.